organizations on a national level. And we identified 2 stories to help share information about your heart recovery program. And the first one is about what all heart failure patients need to know, and it will be tailored to a more trade audience. So this would be shared with your peers in the industry. The next one is on COVID-19 and heart conditions, and that one will also be more trade-facing. However, we might try to send it as well to some more consumer trades, meaning more like a very well health or an everyday health, more health consumer trades. So just to kind of give you an idea on the type of audience we're trying to reach. So it will be the peers in your field predominantly. But on the second one regarding COVID, it will reach some consumers. So we just ask, if you could help explain certain terms to make it more understandable for that audience.
All right.
So without further ado, I know that your time, is, want to be respectful of it. First and foremost, though, may I have your permission to record this call for my note-taking?
Sure.
Great, thank you. So I'll jump in with the questions, and then I'll let John jump in after we finish this round, and then we'll go on to the next topic, if that works for you.
All right.
So can you please tell us about the Heart Recovery Program and what the key offerings are that your program provides?
So it's a program that it was designed as a multidisciplinary approach to address the patients who have a diagnosis of heart failure. So what we have to offer is a continuity of care once a patient is, let's say, admitted to the hospital with a new diagnosis or a worsening diagnosis of heart failure. We treat the patient in the hospital, and we make the transition from the hospital to the clinic with the multidisciplinary approach, with our advanced nurse practitioners, with our pharmacists, with the nurse navigator. So we're able to see the patient in a timely manner, making sure that the patient goes home with all the tools that they need to be successful and not to be readmitted. And so we follow the patient closely, and we have different tools. For example, we have monitoring systems. We have remote monitoring systems, sensors, and simple things like scales, blood pressure, cuffs, and pulse oximetry, things that will be able to monitor the patient at home and then guide them with visits. It could be either in-person visit, or it could be telemedicine visit. So we can titrate the medicines. And the idea is that we give them a plan, and it's a tailored plan, specific for the patient's needs, specific for the type of heart failure diagnosis that they have. We titrate the medicine. So we see this patient more frequently than our regular cardiologist or a primary care physician will see the patient. And we are in contact with the patient and the family, and we guide them to titrate the medicines, to give them the best optimal medicines to their maximum tolerated dose, because we know that those are the doses that can provide the survival mortality benefit and decrease the chances of readmissions and improve their quality of life. So that's like a summary of what the heart recovery program that we currently have.
Great, thanks. You talked about how it was treated and the types of treatment, like making it very tailored. But are there any specific ways that you treat heart failure that you want to share? And then can you share too how care has evolved for patients with heart failure?
Yeah, so heart failure, it's a common disease. So if you think about 6 million Americans have been diagnosed with heart failure, and it's going to continue to increase given that the population is aging. And we used to treat heart failure in a very simple manner with very basic medicines, just because we didn't have the tools, we didn't understand what that means. And so they were getting diuretics and, no more than that. Now, what we do is that we evaluate each patient. We try to figure out what was the specific reason for that patient to develop heart failure. Because heart failure is a syndrome. There are multiple causes. So there are patients that will have the disease that is caused because of coronary artery disease, for example. But those patients might need a different modality of treatment. For example, they might need different types of interventions. It could be either invasive techniques like cardiac catheterization, etc. But if the patient has another type of cardiomyopathy, the ones that we call, for example, diastolic, or the ones that had a preserved ejection fraction. Ejection fraction is a way that we quantify the contractility of the heart based on an echocardiogram or a cardiac MRI. So if the patient has that type of diastolic dysfunction, that it could be caused, let's say, because there's an protein or something that is affecting the heart muscle, let's say a disease called amyloidosis. So the treatment would be completely different from the patient that has coronary artery disease. Or let's say that the patient has some type of arrhythmia. We're always trying to find out, why is that patient having an irregular rhythm? Is it because it's something affecting the heart muscle? So we try to dig into what's the reason. So we have a specific imaging testing so we can diagnose, maybe this patient has another type of diastolic dysfunction, like sarcoidosis, which is in an inflammatory process. So that will guide that patient into a different pathway with different treatments and different medicines. So again, just to give you an overview, that heart failure can be caused by a multitude of different things. And what is important is not just to give the medicines to treat the symptoms, but also to figure out what's the underlying reason, because that changed completely the outcome. And every single one of these diseases have new medicines that improve the outcomes. So, for example, with amyloidosis, is a disease that has new treatments that were not available 3-4 years ago. And we also can provide better outcomes. For sarcoidosis, we'll have to partner with another specialty like rheumatology, pulmonology, ophthalmology, dermatology, because these diseases can be systemic. Let's say that the patient has another type of cardiomyopathy that is caused by high pressures inside the lung. So then we have to diagnose it in a different way, and we have treatment for pulmonary hypertension. And then again, there are like 14 different medicines that were not available 10, 15 years ago. So the importance is not only about the patient, sometimes the family can be affected. So there are some diseases that are genetic. So we offer that as part of our evaluation. In some patients, we find out that maybe the family needs to be tested in order to prevent those patients from developing the disease. Maybe they don't know they have it, so we test some of their family members. And again, there's also a lot of work in conjunction with some other cardiologists. For example, we work closely with the electrophysiologists and with the structural cardiologists. Sometimes we just need to optimize the patient with good medical therapy and then figure out if the patient will benefit, from example, from a specific type of intervention in the valve, and then might need a clip, or they might need a new valve that is being done by the structural cardiologist. So we make sure the patient is in the best condition prior to that intervention. For example, with the electrophysiologist, if the patient might need a specific type of pacemaker, then we optimize the patient. Or if the patient needs a specific type of defibrillator, we give them the best medicine so the patient can see if they recover the heart and if they meet the criteria for the next step, which will be one of these interventions.
Thank you. Are there any innovations that are done by your program that might not be offered elsewhere?
Yes, so we are part of a very active research program. So we have access to technologies that are not available or medicines that are not available because they are not approved. So we screen patients to see if they qualify for some of the clinical trials that we have. And so that would be the difference from some other centers that don't have access to these clinical trials.
Great. And then my next question is, let's see, so you answered that one about how common it is. Do you foresee that other hospitals and other centers will offer a heart recovery program? Do you think that this is like the start of a trend?
I hope it is, because you need to have a dedicated team that it has a multidisciplinary approach so we can make sure that the patient live longer and better. And at the same time, it's going to save a lot of money to the hospital systems if you keep the patient at home and you don't have to waste resources in the hospital.
That's a good point.
You know, there's some penalty for readmission of heart failure. So if the patient gets readmitted within 30 days of being in the hospital, then the hospital will get penalized.
Oh, okay. That's interesting to know. And you said that the candidates are basically, they're treated in the hospital and then referred to you, correct?
That's a subgroup, but anyone who has the diagnosis of heart failure can be seen in our programs. So patients sometimes are self-refer, or some of the patients refer some of their relatives or friends, or the primary care physicians can refer patients as well as any cardiologist or any doctor.
Okay. And then sometimes for these outlets that we pitch, they like to have like a best practices or tips from you on what other centers could do to kind of implement what you're doing. What would you recommend? You said to have a multidisciplinary approach, be dedicated. Are there any other tips that we could add to that?
You have to develop pathways or algorithms. So everyone is aware of what are the things that we need to do when we're evaluating a patient. Where are the check marks that we have to hit to make sure that we're covering everything and we're doing everything consistently. So protocols are very important. So you have to develop protocols and pathways.
Great. Anything else?
Great communication with your colleagues. So it has to be bidirectional. Every time we make an adjustment to any medicine, we communicate with the cardiologist or the primary care physician or the nephrologist or the endocrinologist, whoever is following this patient, to make sure we are on the same page. Everyone is aware of the medical changes, because communication is a key part.
That's great. And anything on that note with regard to maybe involving the family? You had talked about that, you know, that this can be part of a family experience. The family can be affected. Is there anything along that line?
Yes, so it's very important to evaluate what's the social support that the patient has, because if we don't involve the family or the social support system that the patient has, most likely we're going to fail. So it's important to educate the patient, the family, and sometimes these patients have a lot of limitations, or they're elderly or have other comorbidities. They will not be able to remember all the instructions. So we always try to make sure that we involve a relative, someone that they can help us, follow the instructions and help with the medicines, for example. And so that's one of the key parts. Complete integration with the family support. And if they don't have it, then we'll educate the patient to make sure that they can be independent. And sometimes we have to contact home health services to complement or physical therapy or some social services, pharmacies, to make sure that the patient has all the tools to be successful.
Great. And along that line, just thinking in my head, I know that during COVID, some apps were instituted at MCI. Do you use apps to help remind the patients as part of the heart recovery program? Is there any tool along that line that kind of reminds them?
So we are going to start using a program where we are going to monitor remotely some of these patients. We don't have a specific app for that.
Okay.
We have some programs that are commercially available where we can monitor the amount of fluid that the patient has within their pulmonary artery is via a wireless sensor that is implanted, and via internet we can check the pressures and guide the patient. Daily monitoring, we can tell them, okay, you're drinking too much water, or maybe you need more or less diuretics. So that's one of the programs that we currently have. We don't have an app. This is via internet.
Okay, that's interesting. I just want to see what technologies were integrated. And then the last question on this was, well, I think we kind of answered it. It was, why should heart failure patients seek a specialized program like the one offered at Miami Cardiac and Vascular Institute?
And the reason is because we can provide better outcomes. We can improve their quality of life, and so we can make a big difference.
Great, thank you. John, do you want to elaborate with any or follow up with any questions on this topic?
No, you got a very thorough list of questions, and the doctor provided great answers. So I know I'll move on to let's move on to the second set of questions, please. Thank you for
the next one. Of course, the next one is on COVID-19 and heart conditions. What do we know? So this one is very trending. We're going to see a lot of it, especially for Heart Health Month, but also maybe even March. So we might be able to position this several times. So the first question we have for you is, how did the COVID-19 heart program